here tonight is Director of Informatics at University Hospital Southampton NHS Foundation Trust. So not only are loads of these bodies, but they've all got ridiculously long titles, haven't they? All these different bodies. And apparently he's got 15 years experience of building an electronic patient record. So my first question is, have you finished yet?
You never finished.
I'm sure you'll tell us.
That's the good news.
And he's developed a platform called My Medical Record, which is used across the NHS. So please join me in welcoming Adrian Byrne.
So Chris, how long do I have now? Because we're starting later, so...
As long as you like, but half an hour?
Yeah,
You've still got the same time as before. Yeah.
half an hour, okay. So I'll keep an eye on my stopwatch and I'll go, yeah. Okay, so that's me. And thank you very much for waiting, by the way, and delaying whilst Hampshire got their draw that they required to stay in the Championship cricket, which is an unusual game of cricket if you know cricket, 2 innings, but in Hampshire's both innings, extras were the highest scorer. That was the quality that we're talking about. So we can exceed that tonight, I hope. That's me, obviously, and you might see these things around, these pink socks and CIO networks and various things, Interop Summit. So little gangs that Andy was talking about earlier, and I'm a member of those, and I do chair the CIO network. So won't delay on that too much. We talk a little bit about rock stars. So that's me being a rock star. That actually, if you're interested in guitars, is a Johnny Moore signature Jaguar, which is mine, my little present to myself. 30 years ago today, Strange Ways Here We Come was released as an album. So there, that's a nice triv as well. That's me picking my guitar up in LA, actually. So we surveyed the people here, the people who were going to come. We knew what you wanted to hear. Information sharing seemed to be big, engagement in the patient and the public, what's transferable, less technical stuff we know that people wanted to hear about. So I'm going to try and focus a little bit more on these. Clearly engaging patient and the public is a big thing. I am mostly going to talk to you about personal health records tonight, but we were told not to talk about certain things. So I won't mention any of those. But this guy, of course, he wasn't off limits, apparently. Gilbert O'Sullivan lives here. So, we were told that at the museum today as well. So today's presentation, I'm going to talk about personal health records mostly, and the Southampton My Medical Record platform. But I am going to stray into a little bit of technology around open platforms, because certainly I'm a member of a group of people who believe that the future of health informatics has to be in open platforms and sharing data and running multiple applications on top of the same data platform layer. So I'm going to try and explain some of that too. So I thought I'd start by an example actually of a part of our website in My Medical Record that is actually used already by some clients in Jersey. So one of our physicians, Arvin Nagra, she's actually a renal paediatrician, I think you'd call her. She manages some cases over here under a program called Ready, Steady, Go. And the Ready, Steady, Go program is about patients who are transitioning from being a child into being an adult, and they start to take control of their care. And what our website, our My Medical Record website does, I'll show you a bit of that in a minute, is it helps them because they do these questionnaires online, and then that brings them through, and they bring those questionnaires into the record, and they can have an interaction with the clinicians along the way. So they start to take ownership of their own care. Now, what Arvin tells me is that some of her patients used to come over from Jersey to clinic on a monthly basis for appointments, and through using the messaging, she's now starting to spin those appointments, just thin them out a little bit, go 2 months, and hopefully in future, we'll keep reviewing, and it'll be, less traumatic for patients, better for their time. Some of these patients, obviously, they're adolescents. They'll be doing exams and things. It's very inconvenient at times. So this is all good for patients. So I just thought I'd let you know that we're doing that already and working with local people here. So that is our front page of our website. What we run is a website called My Medical Record, and that is our lovely front entrance of hospital there that we didn't spend any public money on. Nice anyway. But this is our website sign-in. Now we run it like it's a website front end, and behind this, in a separate platform, there's a personal health record. And I want to make it absolutely clear that we view that as being the correct architecture and essential for working in the future, because we want people to be able to plug other applications into that personal health record underneath. At the moment, we run the personal health record on our infrastructure within the hospital, but we're moving it into something called the Azure Cloud. If you don't know what that is, it's just out there on the internet, a Microsoft platform. So that's what we're doing there. So we see that separation of those things very clearly. So what is it? It's a content management system on the front. We build pathways. So when clinicians come to us with use cases, we build a pathway, we test it, and then they recruit patients, and hopefully they satisfy these criteria. We're kind of looking for co-production leading to efficiency. So we've got examples of that. So we've got a great program, pre-assessment. So normally, if you're coming in for surgery, you will spend time with an anaesthetist, nurse, up to an hour of time, doing form filling, that kind of thing. So we've got our patients now filling in forms online, notifying their clinicians. Those forms are then saved to their record. The clinicians can then see them in the pre-assessment process. They then can start to assess their list, organise it correctly, spot patients who are not ready for surgery, that kind of thing. And of course, when they come in, then it means they don't have to spend as much time with the staff. So saving staff time, more convenient for the patient. Now, at the moment, we still have an appointment. We just cut the time. But let's say it's an hour's appointment cut to half an hour. We list about 250 of those patients a week in our hospital. So there's a business case for doing this stuff, most definitely. Now, in demand management, best example I have of that is our prostate cancer application. We actually work with Prostate Cancer UK on that. We are their development partner in Southampton. If you're a cancer centre, you'll be signing about 300 patients up a year to a programme which is kind of post-cancer, if you like, just monitoring. And we take that into an online situation where the patients are looking at their PSIs themselves online, and then they don't need the regular outpatient visits that they used to have before, just to come in actually and tell the doctor, for the doctor to tell you that you were all right. And never mind the fact that you may have had that blood test done 3 weeks ago and you've had 3 weeks of anxiety before you get to that clinic. This is what the patients are telling us. So it's good all round, right? It's saving outpatient appointments. Now, you could say we lose income, but it's in the round, and especially as we move forward into more accountable care systems, a saving is a saving for the NHS. So we're taking a rather altruistic view on that, really. And of course, there are also always going to be some cases. And the Ready, Steady, Go is an example of that, actually, when we started. Quality and reputational bonus for us, get patients online, looking at their record, interaction with doctors. But actually, even in those, you do find in the end that benefits will pay off. So, some practical uses of the system. When you log in, we're in our third iteration of the user interface on this now, actually. So we've gone for these button styles now. Obviously, people, tablet devices, that kind of thing, phones. So we used to have a series of menus across the top, and that got very confusing for people. So patients told us to take them away. Just give us these kind of iPad-friendly, if you like, user interface. When you first log in, though, you're going to see your appointments and any new stuff that's coming up. So you can see upcoming appointments, and then they see what they've got coming up there when you first log in. Electronic document delivery, we send all of our letters now to our patients in this. So they could go into documents if they press that tab, and they'll see, and here in fact I've circled this one because this is an example of a getting ready, as in the Ready, Steady, Go programme. The survey is saved as a PDF into the record, and then of course the patient can see it themselves. So that's all good. Anything like discharge summaries, clinic letters, all that kind of stuff all goes in here. Easily visible. Personal information, obviously people can see their demographics, and can update in here. There's an ongoing debate about how much of this information we take back into the clinical record. We do take information off patients into the record, but there's an ongoing debate about what we take out, what they might enter here, or things like any drugs that they might enter that they've been taking and that kind of thing. And that's a debate that goes on between the clinicians and the patients. Obviously, people want to look at their medications, and it's a two-way street, because there's a clinician side facing view and there's a patient side facing view, so both sides can see what the drug regimes are that patients have been on. As I say, that gets updated and can be updated on both sides of the equation. And now we're sort of in quite a few surveys. I haven't mentioned it, but there's around 6,500 patients on this system now in various hospitals, because it's not just a Southampton thing. So it's growing at about something like over 100 a week, but the growth is actually growing as well. So that's the rate that it's going at. Cardiology, colorectal. We've got an IBD program, sort of virtual clinics, inflammatory bowel disease. Doctors there have long clinic lists. They can't really see them all in clinic. So this is helping them to keep those patients away who don't need to be coming to clinic and only be reviewing the ones who need reviewing. So lots of things that we're working on. There's kind of a top level view, if you like, which is just you looking at your record. Great if you're interested. But this is where it starts to get into some of the real benefits and pathways where you can start to analyse use cases for helping the hospital with administrative work, taking out patients' appointments out and things like that. Online journals are a key part of it. These can be used in a number of ways. We use diary functions. If people have got inflammatory bowel disease, they can keep check of what they're eating in here. Doctors can see that, consultant nurses see it. They report symptoms in some of this sometimes as well, and it flips up a questionnaire, and if a patient says something like they're bleeding, for example, clinicians will get an immediate message on that, and then they'll give them a ring. So it's all, it has to be interactive. I do want to make that clear. This is not just a website that you stand up and patients go away and look after themselves. That is not the way any of this works in reality. Secure messaging, I mentioned that. There was a worry actually with the secure messaging. It continues to be a question that gets asked. So you switch this messaging on, I am going to get bombarded by messages. Clinicians may worry about that. So cancer patients, obviously very anxious. What they've actually found is that people switch to this in a very sensible way, and the phones have stopped ringing, which is great because they're just an interruption and inconvenience. And the clinicians take time, they make time available at set times to go through these and answer them. So you can do your work in a much more structured way if you switch on this secure messaging. So it's like email, but it's not email because it never actually leaves the system. So it's all secure. Patient information, quite obviously you want to surface a lot of information to patients. You can put videos in here. All of these are validated links. Clinicians approve this information before it goes onto the website, and then therefore, they're not going into Dr. Google to find out what might be going on. So that's all, really important stuff. Obviously, we asked them a load of questions, including alcohol. That's an example of how the questionnaires work. Just to show you, you know what a questionnaire looks like, right? But if you're doing pre-assessment for surgery, you'll get asked a load of questions. This happens to be one of them. So you can do various things with patients to kind of extract information. Apparently a lot of patients lie about this statistic, which amuses me. I'm sure I would, actually. I mentioned PSA results, so our patients now see, their results which they can look at in a table. Obviously they can chart them. Some things are appropriate to be charted and some aren't. We send a panel of pathology results out to everybody who has a record, and they see them a few days later. We don't release them immediately because we give the doctor a chance to see them before the patient gets them. But it's variable because if you're on the PSA program and you have your PSA test done, the doctors know you're on that program, so you'll have that result back in the same day. And that, once again, is a part of the anxiety reduction. One of the patients waved a piece of paper at me. We have a patient forum every now and then. One of them waved a piece of paper at me. He says, "Why are you sending me this report? 3 weeks ago I saw this online. It's just landed. It's a waste of money." You know, we haven't done all of the process stuff that takes the paper out yet, but the patients are very bought into this, actually. Our oldest patient on this, last time I looked, was 92. So age is not a barrier. So do they look at it? Yes, they do. So I've done a few surveys like this, but I quite like this chart. I love the part that 5% don't know whether they've looked at it or not.
That's linked to the alcohol consumption.
Maybe they're your problem 5%, right? Yeah. So, yeah, obviously nowadays you'd expect a mobile presentation, and the site knows that we use knows when you're on a mobile device you get a different kind of user interface. You know, that is a web app, not an app. There is an app coming. We haven't launched it yet, but that's what we're doing right now. You know, apps are prettier by default, and they hook into the ecosystem on the phone, so you can start using the notifications, that kind of thing. The alarms come up in the phone even when you're not logged in. That's the beauty of using an app. But I think web apps are getting smarter now. So some people think apps are on the wane. Some people think they'll continue to survive, but who knows? We'll play with one for now and see how that goes, I think. There's both options here anyway. I do want to let you know that when you get into this stuff, one of the things you were concerned about really was sharing and consent and all of that. You do get into this concept of a privacy impact assessment, and this has to really be beefed up if you start communicating with patients in this way. I think a sort of normal IT project in our organisation, if you do put in a database that's got patient information in it, there's a privacy impact on the end of the paper, and it's probably, I don't know, a page, if you're lucky. It says, is there any impact on the patient sharing data or anything like that? No, not really, it's all good, it's all interfaced in our network, it's all secure. With this stuff, our privacy impact assessment is now about 60 pages. It's like an ISO 27001 document, all of the security. There's lots of grey areas in here as well, things that are not yet decided. So, patient as data controller, you know, that is not yet decided actually. But what is decided is that as a hospital with an electronic patient record, you are the data controller for that record. Okay, so nowhere is anyone talking about taking that record and giving it to the patient that owns it, and that is the only copy of that record. This is a copy of the record in the personal health record. It is separate from our record. It sits in the cloud. We will have data for what we want. The patient can have that data in their personal health record to share with others, and that's the beauty of the platform, because it's not tethered to our EPR. You don't actually need to be a patient of University Hospital Southampton to use this system, because the data just sits in a personal health record. Hope that's clear. There's a number of things you get into there, clearly. With this, you've got to communicate with patients, obviously, so various ways, use all channels. You know, you're never very successful at communications, it seems, but you've got to try your hardest. Do all your stakeholder reviews. Children and capacity issues, that's a bit of an outstanding issue, actually. You know, and I know it goes on with primary care as well, and Mir's a GP, I know he's probably been through this kind of thing, but you've got someone who has access to their record, like as a guardian, someone has access to their child's record, what happens when they get to 16, 18, or whatever the competent age is for that thing? When do you take the access away for the guardian and give it to the child? So there's a number of unanswered things in here. So this privacy impact assessment, I think it's fair to say, is going to be quite a fluid document as we carry on with it, but we've done a fair amount of work already. So I'm now going to switch to talking a little bit about the platform, and I've switched to Courier font, which is a real IT font, for those people who don't know about that. So, and when it switches back to Arial, then you'll know it's over. So you know, as I said, this is a two-way street. It's not just about standing up a website. It really is not just about wearing your Fitbit, adding things, care plans, that kind of thing, letting patients go and do it for themselves. That all sounds great. Everyone in the new world is going to look after their own health because it's all going to be fantastic. No, actually, there's some of that applies here, because you'll have devices and they will feed data into the personal health record. What our system does is a transactional record. We send appointments, lab results, radiology result messages, secure messaging, and everything through the My Medical Record to the patient. That all sits in the cloud. And of course, they can tell us about things like appointment cancellations, updating things, tell us allergies, medications, something. So it's a two-way street. And we believe in open platforms, as I said earlier. And I thought I'd drop this slide in because until about 2 years ago, Gartner are one of the sort of huge analysts in the world of IT. They tell customers and suppliers what's going on in the market and what you should be doing. Everything's going to be Internet of Things, for example. They coined that term. Leading technology analysts from Gartner have said that the NHS IT market is too reliant on closed proprietary systems and must follow other industries and drive to open platforms and surrounding ecosystems. That is what we're driving towards with this personal health record system. That is the architecture. So a personal health record platform that is open and independent from applications. If we carry on with the kind of explosion of applications for individual purposes that exist at the moment, we will just have chaos. So that explains that chaos, because you cannot possibly interface all of these things to everything else. Just not possible. Now, this is not a new idea. In the world of PACS, which is digital imaging, Lord knows who came up with this idea of calling it PACS, a Picture Archiving Communication System. They call digital X-rays. Who on earth came up with that? But that's what they call it, and it's stuck, PACS. So a PACS system in a hospital looks after your digital X-rays now. Huge data. And when you get to the end of those contracts, a hospital like us, after 5 years, could end up with 50 terabytes of data. Now, that might not sound like a lot if you go down to Maplin's and you can go and buy a 5 terabyte disk nowadays, but actually it is a lot in terms of corporate IT, replicating that data, moving it around. That is a lot of data. You cannot migrate this data when you get to the end of the contract. So if you don't have a vendor-neutral archive where other systems can sit on top of it, not only the system that you bought, you will have a problem at the end of the contract. So what people are doing in PACS nowadays is they're buying a PACS from, for argument's sake, Sectra, and a vendor-neutral archive from, for argument's sake, a company called Acquio. But you can break that link later and put a different system on top. So they did that on PACS a while ago to satisfy that problem. There's other benefits of doing that. You can put other viewers on your system and start to surface the images out into your electronic patient record as well, without actually needing to launch the PACS. So bonus all round. Now, in the world of personal health records, it's the same, or it should be the same, because that cloud-based PHR is the architecture we should be going for. Now, Andy's team actually did a piece of work analysing architectures across the personal health record space and came up with this concept of tethered and untethered architectures. So this is broadly called an untethered architecture because this thing here is not linked to the application necessarily that's talking to it. So somebody could come along and invent an app. So let's say I put all the patient appointments in here, but my application wasn't particularly pretty, but someone else wanted to go and write an app that was good at displaying their appointments, or it linked their appointments with their calendar or something like that, so they could just see them in their calendar application. Then they could do. So it's open. It just has a set of web servers. I won't go into this technical detail here, but HL7 Fire is the interfacing standard. Interopen is the shirt that Amir has on at the moment. So Amir kind of runs a group called Interopen, along with a few others. He doesn't do it all on his own, but he seems to spend a lot of time on it. This is a group of people that are trying to get interfacing standardized so that this openness can work and so that these other applications can talk to it. And then you can start to plug in. This is a long-term condition. Sorry for the acronym, but in health we kind of talk about things in this way, don't we? Long-term condition application, lifestyle application. They can start to send their data in to this open platform, and it becomes something that's actually owned by the patient. They can take it around, have it on their phone, they can show it to people, and if they go to somewhere that's got the capability of interfacing, then let's say a different hospital, they move out of area to a different hospital, it is possible for other people to write applications that sit on this platform. So I think this is a very important piece of work. We are sponsoring this, if you like, in Southampton. We're standing up a service at the moment as we speak. It'll be live before Christmas. Fire compliant, PHR in Azure, in live and test. So we're going to stand this as a service up in the cloud so that other people can potentially work and play with it. So I'm talking to folks in Southampton University. Obviously they have software developers. They can develop applications against this and then start to talk to us about whether they're useful. They won't need to see any patient information, which is great. So they can, in other words, they can kind of go at it and there's no information at risk. But when they want to put something live, they can then talk to us about whether it's useful to put that live. So I think this is a really interesting way of working. Potentially opens up the market, which, going back to what Gartner said, the market has been closed for too long. So open platform PHR. If every app has its own data platform, it will be chaos. We'll have no sharing of data. Everyone will need a username and password to get into every different application. All that has to stop. Every app will have to have its own user account process. So we do need a PHR platform that works like a vendor-neutral archive, and we do need a federated identity scheme so that people can log in to their different applications with the same username and ID. That is the IT stuff over. I'm switched back to Arial font. These are the organisations, roughly a map of the organisations where we're working. The numbers aren't accurate because the thing is at least 6 months old, but we're working with Truro Hospital, obviously Southampton, Bath, Dartford. There's about 5 hospitals in Liverpool that we're working at actually, and the map shows is based on the postcode of the patients that are working in it. So it's of course down here somewhere is Jersey. That's why it's not showing on there. No, what that shows is that through providing an open architecture, you can scale things up and you can spread them widely, because none of this is tethered to the Southampton patient system. So that's just a demonstration of how that can work. Now, I thought I'd finish with a couple of things, actually. A couple of things that we're thinking about doing in the future. Someone tells me there's an alcohol problem in Jersey, and I think I might be a part of it later. But I don't know if you know The Simpsons, but that's Mo Sislak, Pretty Boy, and Homer. But we've had one of our clinicians has been working on a piece of research now for. How am I doing for time, by the way?
Oh, you're fine.
Yeah.
Fine.
Has been working on a piece of work with liver disease for a couple of years now. He's been getting the data out of our order communication system and a couple of other things to look at it. Liver disease, in case you didn't know, is a completely silent disease. It has your liver has no pain receptors. It can't tell you it's ill, basically. So when you turn up to see this consultant in our hospital, it's highly likely that you're going to die. You'll take about 12 to 18 months doing it, and in that time you'll cost the health service about £800,000. The liver is a very resilient organ, actually. If you survive that period, that 6 to 12 months, and you're getting better, you will fully recover probably, provided you don't have certain other complications. So it's very resilient. So it's really important to know if you've damaged your liver and to what extent early on, because you can do something about it. And there's good evidence to show that people who know that they have early onset of alcoholic liver disease do change their habits very quickly. You know, if you told me right now that I had damaged my liver through drinking alcohol, I'd just stop drinking. You know, because that's what people do. Now, our liver consultant in the hospital has worked on this algorithm. It's not gone quite through all the research, ethics, testing, all of that kind of thing yet for poor release, but you can spot this early onset. And what we're thinking of doing when we get the chance to actually run it is we can have a patient logging into their personal health record and have them run the algorithm on their own data, which will let them know. Because the trouble is, this is a silent disease. People will never come to the doctor and say, doctor, I think I've got early onset of liver disease. Right? So it's a way, and we cannot just go and run this test on the population because we're not allowed to from an information governance perspective. So we're in this situation where we know there's about 4 or 5% of patients or people across our area in Southampton has this disease, but we can't go and tell them about it. Personal health records give you a chance to do things like that, yeah, to run that kind of study and make it available to patients because they can decide for themselves what they want to do with their data, what tests they want to run on it. They'll know it's a validated algorithm, that kind of thing. I'll give you a couple of other things we're thinking of doing. If you go to your GP as a woman in her 40s, let's say, you satisfy certain criteria, you've got breast lump. In England, they're always, at 100%, they're going to refer you to a 2-week wait clinic and outpatient to see a consultant. Yeah? In that interim, the way the system works now, you will have to book an appointment with your GP. That's hard work. Yeah? Wait for that, go through that, then go through the fact they're referring you, and then you'll end up where you should have ended up at the first place. So here's another thing you can do with personal health records. People who satisfy criteria should be able to refer directly into those 2-week wait clinics. Yeah? So that's another aspect that we're thinking about doing. There's another one, it's a similar thing, but if you're suspected osteoporosis, the current pathway is you'll come in, you'll see a consultant in outpatient, he will refer you for something called a DEXA scan, then the results will come back, then you'll go back to see him and he'll tell you it's all fine, then you'll go away. You've had 3 appointments to do that. Yeah? Take time off work, all that kind of thing. Now, once again, if you satisfy criteria, you should just be able to go straight through to a DEXA scan. And if the results are normal, that result should be sent back into your personal health record. The system will notify your GP and the people in the hospital that was normal. You don't need to do anything else, that's it. So there's lots of opportunities. I can tell you something, we are not short of ideas or short of work on this. There's a pipeline of ideas. So I'm going to finish with a couple of statements from patients. This someone, an IBD patient, who I do actually know this lady. She speaks for us occasionally. She's kind of a really good patient of ours, if you like. She's going through a rough patch. Good to know that people were keeping an eye. If my weight went down too low, I'd automatically get contacted by a member of the clinical team. This lady actually has done some really fantastic things with the data. She's downloaded the data out of her personal record, got it all in a spreadsheet, made a note of what she was eating, what drugs she was taking, and the impact that they've had on her care. She's really taken her own care into her own hands. Now she's handed that back to us in terms of the spreadsheet. We've handed that back to our development partners, but they're based in the US actually, I didn't mention that. So the people who build the content management system this we work with are based in Maryland, US. They're called Get Real Health. So they've taken this back and they're looking at ideas to build that kind of application functionality in now because it's just so good. So this patient has actually designed that for herself. And yeah, I hate this issue of being in the dark all the time. We live from result to result. This is a prostate cancer patient. So I feel I'm part of the team, not waiting for the answers. I'm up there with them now. So finish on that one. Thank you.
So we do have time for some questions of Adrian. If anyone's got any questions, we've got a mic here. If anyone's put their hand up, if they've got a question. A couple at the back.
Hi. Do you do any kind of accessibility testing of the app for visually impaired?
Yeah, we've been doing some work on it, because it's all work in progress, everything really. So Arvind has had someone working separately on different user interfaces for people who are visually impaired. We haven't released any of it yet. I think there is some native functionality in the Get Real app for it too, but I couldn't swear to what that is. I know that Arvind, the physician that I mentioned, has been doing some work on that separately. Yeah. It's an important piece of work, yeah. But, we try not to get bogged down with the small percentage of people, some people come to me and say, well, what about people who haven't got a computer? There's all kinds of things like that. But you know, we try and address the main problem, because in the end that frees up time so you can deal with folks, because we're not taking anything away actually. All of the traditional ways of working with the hospital are still there, obviously. So it's about freeing up time for them. But I think it is important that, you know, visually impaired people, for example, and there will be others, you know, people are hard of hearing, can we do other things? You know, there will be different use cases. We're not, you know, we haven't done 100% of this yet. I don't think we'll ever finish, you know.
It was actually the same question I was going to ask, but it's like a capability assessment as to people. You entrusted the patients to be able to use the system, and you've answered the question, so I'm just going to hand it over.
Okay, I will say though that, you know, in terms of trusting the patients to use the system, what has proved very valuable is, well, first of all, recognising that this is not just about standing up a website and everyone gets on with it, right? They don't. So the prostate cancer people, they get their patients into a workshop, they go through it, they kind of have an onboarding process, if you like. So they're tested as being competent before they go, yeah.
Thanks very much for your talk. It was very interesting, and I love the idea of a sort of patient-centred record that you own. What does it keep it running behind the scenes? How do you support it? Staff, have you got techie backing for this?
Well, we've got this far with remarkably little staff, actually. You know, just between, I would say, 2 to 3 staff in the IT team, plus we've had some support from Prostate Cancer UK in terms of they've put support workers out there. So out in the clinics, you know, if you're going to run a service like prostate cancer, you're going to need a support worker working in that. So that's outside of our team. Back in IT, you know, this is a content management system. The beauty of that is, if you come to me with a use case for a pathway, I don't need a software developer. It's mostly just configuration. We can turn around a prototype and give it back to you in a few days. And that can be very close, actually. So we're talking to the community diabetics team at the moment. We didn't do anything with diabetics first up, really, because we don't see a lot in the hospital, you know, it's not our service. But they started to talk to us about it in community. And we said, oh, we'll stand something up, you know, we'll do a prototype. You know, a lead developer on this, Kev Hamer, he developed something in a few days. They came to a meeting and said, well, we've knocked this up, what do you think? And they said, oh, we think that's ready to go, we can start using it. So in terms of support, as I say, this is a content management system. It is supported by an external company in terms of the back end, the engine, all that kind of stuff. So we don't get involved in any of that. And as I said, we're talking about putting the actual PHR bit of it is going up into the Azure cloud. So that would just be away from us. So all the kind of security testing, penetration testing, and all of that we have to do because it's a service that's facing the internet. You know, we just want away with that. So I'll give that to Microsoft because that's the stuff they do really well. So we're going to put that in there for them. And we will not manage anything other than just the interfaces.
It was really interesting that. I suppose my question is the importance of my medical record, the challenges facing the health service and indeed hospitals about my medical and social care record.
Mm-hmm.
And I wonder if you could just talk a little bit about the potential for this to develop of technologies like this into that wider field of health.
So when we first started doing this, we were working with Microsoft on the actual PHR platform as well, actually. We've kind of moved away from that for now because we're not sure what Microsoft's future is in that area. But certainly their ambition was a record that sat in the middle of all of the care services, including social care. This does not exclude anyone. If you can write a FHIR API interface and connect to this service because it's in the cloud, then you can use it. And if you've got a use case for it, there's nothing stopping you from using it. It's completely open. If there's a use case, then you can use it. We haven't done any of that yet.
You talked about results and appointments. Does it show notes about individual episodes of care? And if it does, do you ever get any challenges or disputes from patients about these, and how do you deal with them?
So I'm not really sure. Can you clarify what you mean? Is that
if, for instance, a patient didn't agree with what they're seeing on the record that's been sent from your repository?
We've had a couple of instances where people have challenged what was in their record. I couldn't give you any specific use cases, but obviously that results in a discussion, you know, and things can be updated. Generally, I mean, I also manage medical records, and this happens in the old way as well. You know, people do a subject access request in their record, and they go, I don't agree with what the doctor's written about me there. But actually, you know, that's what the doctor wrote. He cannot go and change that. I mean, I'm not sure Amir, but that is true, isn't it? Yeah.
You'd have to have very compelling reasons to actually go back and change it. You could, normally if I get challenged and I don't agree with the challenge, I'll just make a note of what the patient said. But, you know, actions have been made based on the decisions I made at the time, and those need to be documented for medical and legal purposes, as you can understand. However, I would document what the patient said and any reasoning behind that subsequently.
So I'm aware that there are patients who've seen things they didn't like as well. So obviously cancer is the big one. You know, letter says I've got cancer. Doctor didn't say cancer. He might have said something. He might have said a lot of words. You were in clinic. You were confused. You know, but the letter says cancer. You know, can be distressing. You know, so we've got a kind of a variable sort of pointer on that, really. You know, we started out releasing everything. We maybe stopped releasing some of the scanned information because we couldn't be absolutely sure what was in it. I think direction of travel is definitely that patients will get to see everything. We're on a kind of a journey, if you like. I hate the way people say we're all on a journey, but it is a kind of a journey. And we'll get there where the patients are seeing everything. Right now, we're in a society that is almost like paternalistic, if you like, about patients and their record. Oh, doctor said this, doctor's looking after me. I think we're going somewhere else on this. I think patients will start to take more of a 50-50 relationship in some of this stuff, and they'll see everything. But we're not there yet, and it's quite a sensitive area.
A few more questions. The gentleman in the middle, and then we've got two up here, and then we'll have time for questions of the panel as well.
That was all very interesting. I'm slightly concerned, how do you tag the patient record to the individual? How do you identify it? And at the moment in Jersey, I have my social security number,
Yeah.
I have my patient number, I have my medical records number, and when I was treating prostate cancer, I have a different number that applies to Guildford Hospital.
Right.
Too many numbers for me.
Yeah, yeah. So obviously you'll get a login to the site, which will not change. But the key question there is, how do you initially authenticate yourself? How do we know you are who you say you are, and go through that process of identity? So at the moment, we have vouched for everyone who's on here. So you're already in treatment with us. We give you a username and password to the site. The site knows your NHS number, and that all links through. Now, if you're on Jersey with prostate cancer and maybe you had some treatment at UHS but you're back here and you've got a record here but you're having your blood tests and they're done in Jersey, you know, at the moment those results would not flow automatically in to our record because there's no interface there. They could do, because we do that with Liverpool, but not everyone is doing it yet. So, and we're having some discussions about things like home testing kits as well, so, or possibly a kit where you can have your blood taken and send it to our lab and the results will flow in. There's a number of ways that could work, but in the end we'd like the results to flow into the record automatically. Yeah. This, in the end, your personal health record will be your personal health record, and it's up to places like, let's say Jersey, let's say Guildford, to hook up to that so that you have one experience. You know, I wouldn't expect you to have to do two different things.
But would that be tagged into my social security number?
Doesn't use your social security number. We use NHS number as an identifier. Yes, we do. It's one of the key identifiers. But in the end, the unique identifier for your personal health record will be the identifier that you use to log in.
Just a couple more quick questions. Philip, do you still have a question? Philip, microphone.
If there was two things that you could do, so Jersey's tiny, but we're in theory fast, nimble, and fast moving and move faster, what would you put as the opportunity for Jersey to deliver better patient healthcare in terms of what you're doing? Give me a couple of tangible examples where we could leap ahead because we're Jersey?
Well, I think I would say take something that's already built and start using it, clearly, because then you get off the ground quickest. You know, you have cancer patients the same as everyone else does, so there's a number of cancer pathways that we already built. So I'm not sure whether you're talking about working with us. We do work with others, as you know, and we'd be willing to work with yourselves. But if you wanted to get on and do something, identify use cases, what are your problems? You know, where do you think you can cut out outpatients, that kind of thing, what you're trying to solve. I think interfacing is a key thing that I would point at. You know, if you've got the capability to do interfacing, and I happen to know that on the island you've got something called InterSystems Ensemble as an integration engine. We use that ourselves. That's like a message broker that passes data around. You've got an opportunity to use that to connect to a personal health record. I'd say you could do that. I'd say if you wanted to, we'd be willing to talk to you about pathways that we've already built, so they're off the ground and could be done quickly. So yeah, if you want to give two things, I would say those two things. I also know that you're already out of about £10 million that the Highland spends on UK mainland, about 4 million of that is us. So there are a number of patients that come already cross between the two hospitals, and there are therefore other benefits in a hookup via a personal health record between the two, because then you could share the information with the site that they're going to, and we could pass information back potentially.
I think we can explore a bit more of that on the panel as well. Final question, because I've got a lot of job titles to read out for Amir in a minute.
I'm a relative newbie to Jersey. I've been working within the NHS for 30 years, and it's a very interesting, and I'm aware of the work that you've been undertaking. With regards to mental health, will mental health be an addition to this service? And what was interesting as well was the map that came up, because I expected all of your sites to be within NHS England, and surprisingly there were some sites in Scotland and Wales. They
were based on the postcodes of the patients, so it depends where they're being treated.
So is it within NHS England, and you haven't managed to sort of cross boundary within other?
We are not working with any hospitals outside of England at the moment, unless you count Cornwall, which clearly is outside England.
I just found it quite fascinating to thought, oh, that's interesting, how we manage that one, but yeah.
So mental health,
yeah.
We don't have a use case for mental health. As I said to the gentleman at the back, you know, if there's a pathway, it's easy to build stuff. You know, I don't know if you're aware of hospitals. What's it called now? South London and Maudsley, SLAM, big mental health organisation. A few years ago, they stood up a service very similar to this for their patients, doing mood analysis, that kind of thing. I'm quite good friends with a guy called Joe McDonald in Newcastle. He chairs the Chief Clinical Information Officers Network. I chair the Chief Information Officers Network. Joe is a psychiatrist. His stated aim for getting involved as a Chief Clinical Information Officer is he wants to find a cure for what's it called? Schizophrenia, isn't it? That's what he says, isn't it? Cure for schizophrenia. He's very interested in this kind of platform for his patients as well. It's a kind of, what we don't know at the moment is what works, actually. You know, that's the interesting thing. I mean, there's a site called Big White Wall, which is very popular. Lots of mental health patients have an account on that. It's great because it's a peer group kind of thing for people to talk about problems and stuff, but it's not integrated with anything. I mean, the beauty of doing something like this is it starts to create a conversation between clinicians and patients about their records. So it's a different level of technology.
Thank you. So thank you for a very powerful presentation, Adrian. Thank you.